All right, let's jump right in. Today, we're going to tackle one of the most fundamental challenges in medicine, and that's really understanding normal aging. We're not just going to list off a bunch of facts. Instead, we're going to build a mental model, a framework that you can actually use at the bedside to make better clinical decisions. And this is the core question, isn't it? As a clinician, you're constantly trying to figure out if what you're seeing in a patient is just an expected part of getting older or if it's a red flag for a distinct disease. And believe me, getting this right is absolutely critical. So let's start with the basics. It's so important to get this. While aging does follow certain predictable patterns, it is an incredibly individual journey. What happens in one person at age 80 might look completely different in another. Okay, now the key phrase in this definition, the one I really want you to focus on, is increased susceptibility. See, aging itself isn't the disease, but it kind of sets the stage. It makes the body more vulnerable to problems, and it is not a one-size-fits-all process. Your genetics, your lifestyle, the environment, all of it creates this huge spectrum of how people age. Let's make this crystal clear. Normal aging is really about a gradual loss of reserve. You can think of it like the body's buffer system getting smaller and smaller. A disease, though, that's a specific, distinct pathological process. And this example is perfect. Anemia is never a normal part of aging. An older person might be more susceptible to the causes of anemia, but the anemia itself is a disease state that you absolutely have to investigate. So how do we organize all these changes in our heads? Well, this is where that framework I mentioned comes in. We can really understand the how and the why of aging through 3 core principles. This is the conceptual heart of what we're talking about today. The first, and honestly the most critical principle, is something called homeostasis. Think of it like this. As we get older, our body's amazing ability to maintain balance, homeostasis, that ability narrows. That safe operating window we all live in gets progressively smaller, leaving a lot less room for error when things go wrong. And here's a really powerful way to picture homeostasis. Imagine you're walking on a path right along a cliff's edge. When you're young, that path is wide. You can stumble, you can trip, and you can easily recover. But with aging, that path gets narrower and narrower. So now, a small stumble, a minor illness that you would have brushed off before, can be enough to push you right over the edge. Okay, our second principle is a loss of complexity. Healthy, young systems are incredibly dynamic and adaptable. They show tons of variability. Just think about how your heart rate is constantly adjusting second by second. Well, as we age, our systems tend to become more rigid, less responsive. That loss of dynamic variability is a real hallmark of an aging system. And finally, our third principle is inflammaging. This is the idea that with age, the body develops this persistent, low-grade background hum of inflammation. And this isn't from an infection, it's what we call sterile. But this constant inflammatory state contributes to so many of the vulnerabilities and diseases we see in our older patients. Okay, so we've got our 3 principles: homeostasis, loss of complexity, and inflammaging. Now for the fun part. Let's put this framework into action and see how these concepts actually play out in the specific organ systems you're dealing with every single day. Let's kick things off with the kidneys, a textbook example of homeocynosis. On average, we lose a pretty significant chunk of our kidney mass by age 80, and this results in a steady decline in function, a classic shrinking of that physiologic reserve. The kidneys still work, for sure, but their capacity to handle stress is way, way lower. Okay, now this right here is a huge clinical pearl. You need to burn this into your brain. Why on earth can a patient lose 40% of their kidney function and still have a totally normal creatinine? Well, remember, older adults also have less muscle mass, so they produce less creatinine to begin with. The bottom line is this: never, ever assume a normal creatinine means normal kidney function in an older patient. The cardiovascular system tells a really similar story. The big arteries get stiffer, which makes the heart have to work harder. That's increased afterload. Your max heart rate predictably goes down, and the heart actually changes how it fills with blood, becoming way more dependent on that final kick from the atria. This is so common, in fact, that hearing an S4 heart sound, which is the sound of that atrial kick, can be a completely normal finding in a healthy older adult. So let's bring it all together. This framework, these 3 principles, helps us understand one of the absolute biggest challenges in geriatrics: why older patients so often present with atypical symptoms. It all comes back to that narrow path on the cliff's edge. I just love this quote.
It so perfectly captures the fragile state of the aging brain. It's in an uneasy truce, where its reserves are just enough to maintain function, right up until they're not.
And this is a perfect illustration of that truce breaking down. Why does a simple UTI cause delirium in an 85-year-old? Well, first, their anti-confusion reserve is already low. That's homeostasis. Then, the infection, even a minor one, is enough of an insult to push them right across their physiologic threshold. The brain, in this case, is the system that gives out first, and the presentation is confusion, not the classic bladder symptoms you'd expect. So, as we've seen, aging brings all of us closer to these clinical precipices. But the rate at which that happens and the life that follows is incredibly diverse. We have to learn to look beyond just the number of candles on a birthday cake. Just look at these numbers. I mean, look at the variability just among 85-year-olds. An 85-year-old man in the healthiest group has nearly 3 times the life expectancy of someone in the frailest group. This is exactly why functional status, not just chronological age, is so incredibly critical for your clinical decision-making. And we're going to end with this. This simple phrase really says it all. It encapsulates the most important lesson you can learn. There is no such thing as a typical older adult. Every single patient is an individual, shaped by a totally unique mix of genetics, lifestyle, and life events. Your job isn't just to know the facts of aging, but to figure out how to apply them to the one unique person sitting right in front of you.